We now move on to our next session. I hope everybody is up and above and bright and awake. Hello. Yes, thank you. So I would now request, moving on to our next session, we have Dr. Jitendra Sharma with us. He is also an awardee of FICCM Award 2019 for Best Critical Care Specialist in Delhi, NCR 2018, Indian Healthcare Award in 2014, and Hansraj Nayyar Memorial Award for Best Paper in 2009. Thank you, sir. Thanks for being here. I would, since Dr. Ashish Agarwal is not able to join, may I request Dr. Saurabh Das to kindly chair the session, please. Dr. Saurabh Das is a senior consultant at Max Hospital, Shalimar Bagh, as you all know. Thank you.
So our CM present speaker. Over to you, Dr. Sachi.
Thank you, Dr. Jitendra, for the kind introduction. I would also like to thank the organizers for having me here. So the topic given to me was whether to use monotherapy or combination therapy for gram-negative sepsis. Let me switch on my timer. Yeah. So I'll touch a brief about various aspects here. So William Osler very famously said that the person who is ill has to actually recover from two things. One, from the illness, and second, from the effects of the medicine that he has taken to cure that illness. And this stands true even for day-to-day practice. We are treating something, we also see certain side effects of the drug, and the patient suffers from both actually. When we talk about resistant categories, we know these terminologies: MDR, XDR, PDR. So multi-drug resistance, extensive drug resistance, or pan-drug resistance. So definition-wise, MDR stands for non-susceptible to more than one agent in at least 3 classes of antimicrobials. When we talk about XDR, so they are only susceptible to, let us say, tigecycline and colistin. This is what we see in our culture reports. And when we talk about PDR, it means it is resistance to everything. So even tigecycline, colistin is also resistance, and this is the difficult to treat bug that we are talking about. The greatest danger in critical care is named as escape. Enterococcus, Staphylococcus, Klebsiella, Acinetobacter, Pseudomonas, and Enterobacter species, and these are the ones which form almost 90% of your culture reports. Even if they are negative, you try to target these bugs because you suspect that this is the infection that your patient is having. If you look at the history wise, right in 1980, the first ESBL was reported. So we are talking about 3 decades back. Also the ESBL was an issue 4 decades back. And now, as time has gone by, in 2010, the famous NDM came into the picture, New Delhi metallo-beta-lactamase, and other resistant mechanisms for almost all gram-negative bacilli that we see. So we are talking about E. coli, Pseudomonas, Acinetobacter, Klebsiella. So now we have resistant mechanisms very much prevalent in this system. And if you look at the resistant scheme, so this is an AMBER classification. So AMBER has classified as A, B, C, and D. And on the basis of that, if you look at the important ones, so if you talk about the KPC and the TEM1, we'll look at that the main bacterial substrate which is getting resistant is penicillin group or cephalosporin group. And if you're trying to add a BLI to it, so whether that is tazobactam or clavulanic acid, you're trying to counteract this kind of mechanism. The same happens in AMBER class B, where IMP1 and VIM1 is there, where carbapenem is the affected drug, and you're trying to compensate this by adding EDTA nowadays. Amber class C, where again E. coli AMC is there, it is specifically resistant to cephalosporin. And when we talk about amber class 4, amber class D, the OXA group, the OXA 48 is there, and you try to again add certain BLIs to counteract this mechanism. This is how the amber has classified, but actually it doesn't, it is not so simple to put two drugs together and your Klebsiella will get treated. So when we decide about mono versus combo therapy, there are number of factors which have to be taken into account. What is the phase of infection? What is the kind of infection? And are there any concomitant diseases the patient is having? Similarly, what is the severity of the disease? Is there specific antibiotic which is being given, or there a specific resistance mechanism? And what is your local antibiogram that is there? So what is your epidemiological data? When we talk about MDR, we have to also consider who will have MDR. So what is that at risk population? So anybody who has had previous hospitalization within 90 days and has received antibiotics, presently in the hospital for at least 5 days or more, then he's coming from a community where the resistance is higher side or has been in the hospital in and out, or there are other risk factors. If you talk about specifically about healthcare associated pneumonia, so hospitalization for more than 2 days, is coming from a nursing home, has a home infusion therapy, is a chronic kidney disease patient on dialysis and or on immunosuppressive therapy. So these are risk categories for MDR as well as for hospital acquired consolidation. So now let us first look at what is the difference between monotherapy and combo therapy and what is the data which is there. So this was 2021 systematic analysis and meta-analysis where they looked at combination therapy versus monotherapy for carbapenem resistant gram-negative bacteria. 52 studies were taken into account, out of which 5 studies were RCT and 47 were non-randomized studies, and roughly 6,500 patients were enrolled. And when they looked at mortality comparison between mono versus combination therapy for carbapenem resistant gram-negative bacteria, what they found was combination therapy had a better outcome. Now when they looked at clinical cure, they looked at microbiological cure, and they also looked at outcome, mortality data at 90 days. They found that patients who were given combination therapies did better in all 3 aspects as compared to monotherapy. Now when they looked specifically for carbapenem resistant Enterobacteriaceae, again the same result came into picture. Combination therapy did much better in terms of clinical cure, less number of relapses, more microbiological cure, and less mortality. So combination therapy did better as compared to monotherapy when you're targeting this group. When they looked at all infections irrespective of the only one group, so when they compared bloodstream infections, HAP, intra-abdominal, urinary tract infection, or just pneumonia, what they found was in most of the data except intra-abdominal infections, they found in all categories combination therapy had a better outcome as compared to monotherapy. Only in intra-abdominal infection they found that it was equivocal. There was no additional benefit of adding combination therapy. And they concluded that overall monotherapy has more adverse effects than combination therapy, and infection patients with carbapenem resistant gram-negative bacteria may benefit from combination therapy. Then another review where it looked again for multi-drug resistant gram-negative infections, again in 2019. 53 studies were there, 4,500 patients, and among this 41% received monotherapy and 59 received combination therapy. And they looked at various organisms. They looked at what is the effect in MDR Pseudomonas, in MBL Pseudomonas, in MDR XDR Acinetobacter, in mixed gram-negative bacteria, and in CRE. And what they found was in almost all category of organisms, the combination therapy had a better outcome as compared to the monotherapy. And when they looked at different clinical cure rates, that was a mortality, and again for clinical cure rates it was found to be better. So combination therapy again did better when you're targeting a organism wise data. So one study looked at various sites of infection, the other study looked at various organisms, and does it really is organism specific that you should give combination therapy, or is the knowledge equal to all the kinds of bacteria. In 2014, this was a short communication where it looked at what should be the concept in combination antibiotic therapy, and they said generally it works on 4 basic principles. You want to broaden your antibiotic spectrum, you want to cover polymicrobial infections, you want to create synergy, and you also want to counteract antimicrobial resistance. So let's say drug A has encountered antimicrobial resistance, so addition of drug B will basically help in counteracting that, and one of the drug will be acting. So this was the whole mechanism. And what they said that if you are suspecting a patient with MDR infection, start with a broad spectrum antibiotic. Once your microbiological data is available, look for carbapenem resistance there. If your patient is sensitive, then you can continue with monotherapy. But if you feel your patient is carbapenem resistant, then you have to add a combination therapy, and then combination therapy will depend on your genotype and the local antibiogram. In 2021, this data came where they looked at what is the relation of polymyxin monotherapy versus combination therapy when you're targeting multi-drug resistant infections. And when they looked at mortality effect, which was combination with carbapenem, if you're combining with carbapenem, the combination therapy did much better as compared to monotherapy of polymyxin. And when they looked at all-cause mortality, which meant all these 50 studies, whether there was combination only with carbapenem or combination with anything else, when they looked at, again it supported combination therapy of polymyxin B with another drug. So combination is better even if you're giving polymyxin. So monotherapy of polymyxin may not do that justice. This came recently where again they compared drugs. So here they looked at what happens if you're just giving colistin versus colistin based combination therapy, tigecycline versus tigecycline combi therapy, inhalation colistin versus combination, and other combination. And what they found that in most of the categories, the combination therapy was better. So when you're targeting drug wise combination also, so the combination therapy will do better in treating these patients. Only this study, which is recent study 2023, right, they said that if you are giving combination therapy for Pseudomonas aeruginosa in VAP, the number of mechanical ventilation days and length of ICU stay was higher in the combination group as compared to the monotherapy group. So what are the therapeutic options when you want to treat these MDRs? Either you use non-standard antibiotics for which resistance has still not been documented, or you use higher dose of standardized antibiotics in an attempt to achieve PK/PD targets, or use a combination of these two options where you can juggle around and try to create a regime of your own. So combination therapy is actually meant for very critically ill patients, and it is usually on the premise that you give a cornerstone drug for which the organism has shown in vitro susceptibility. You combine it with any other drug for which the organism may or may not show an in vitro susceptibility. And commonly used drugs which with polymyxin are carbapenem, tigecycline, fosfomycin, renal safe aminoglycosides, and rifampicin. In Indian subcontinent, where rifampicin is taken with a pinch of salt because it's a famous anti-tubercular drug, so you don't want to start using this and create more and more resistance. I'll not go to that slide. Now this is the prerequisite. If somebody wants to give monotherapy, there are certain prerequisites. We should look at patient parameters. So the patient should not be in septic shock. There should be a localized infection. Patient should be clinically improving on the receipt of an antibiogram. There should not be major comorbidities, and there should be lack of risk factors for suboptimal drug exposure like morbid obesity, augmented renal clearance, or unstable renal function. If you look at hospital parameters, the MICs should be within the breakpoints. No other concomitant infections should be there, and no extreme bacterial load should be there. When we talk about pathogen parameters, there should be therapeutic drug monitoring availability. Patient should be able to manage the adverse effects if there are any related to the drug dosing, and the team should be capable to handle MDR, XDR pathogens. And when we talk about antibiotic parameters, there should be no previous toxicity issue. You should be aware of how the PK/PD works. Will it require a continuous infusion or a bolus dose or frequent dosing? And there should be less risk factors for selection of resistance. So if you have these parameters ticked, yes, you can think of monotherapy, which probably in an ICU scenario will be, suitable only to, let's say, 10-15% patients. Otherwise, you will think, if you're thinking of infective patients, if you're thinking of critically ill patients, probably you may not opt for monotherapy. So when we talk about CRE, and if you're thinking about empiric treatment, and if you know that there is known colonization or there is a local epidemiology with more than 20-25% prevalence of carbapenem producing an ESBL producing Enterobacteriaceae plus any of these factors, you have to look at combination therapy, and combination therapy could be double or triple to increase the probability of adequate trial. So if you are using ceftazidime, avibactam or meropenem, vaborbactam, which the other combination is still not available. If you are looking at the first combination, then you can add gentamicin or any other aminoglycoside, fosfomycin, colistin and tigecycline. And if you want to give a colistin based combination therapy, then carbapenem, if your epidemiological data witnesses an MIC of less than 16, along with either an aminoglycoside, fosfomycin or tigecycline. When you're targeting definitive therapy, almost the same regime is there. When we talk about pseudomonas, MDR pseudomonas, when we talk about dual anti-pseudomonal combination, so first anti-pseudomonal agent could be ceftazidime, avibactam, meropenem, vaborbactam or piperacillin, tazobactam, even ticarcillin, clavulanic acid could be added. You have to add a companion anti-pseudomonal agent, and it could be gentamicin or aminoglycoside, colistin or fosfomycin. Remember, tigecycline has an in vivo resistance, so please don't think of tigecycline whenever we are looking at pseudomonas. When we talk about definitive therapy, if you are looking at monotherapy only, if you have tick boxes there, otherwise it will be a combination therapy, and you can look at beta-lactam based combination therapy where these beta-lactams along with either an aminoglycoside or a fosfomycin should be given. So Professor Bessetti in 2019 says that if you have a CRE, your regimen should be ceftazidime, avibactam as a preferred empirical choice for both KPC and an OXA, or meropenem, vaborbactam if the availability is there. Along with it, you need to have a combination of certain drugs, and that combination could be colistin, poly-B, tigecycline, any other aminoglycoside or fosfomycin. And if you want to consider BL, BLI, and in case there is resistance there, then you can think of polymyxin based combination therapy where either aminoglycoside or even double carbapenems or fosfomycin can be given. And whenever you are using polymyxin B, always look for inhalational. For CRPA, which is pseudomonas, carbapenem resistant pseudomonas, ceftazidime, avibactam along with any other second anti-pseudomonal drug plus a combination with either colistin or poly-B should be given. And if you are looking at Acinetobacter, again polymyxin B should be the backbone agent along with carbapenems or aminoglycosides or tigecycline, fosfomycin, and always look for inhalational if you are using polymyxin B along with it. So these are the therapeutic options. You have carbapenem resistant, then you look for your genes. So if you have an MBL, you will look at ceftazidime, avibactam plus aztreonam. If you have an OXA48, obviously no aztreonam, and you will have ceftazidime, avibactam. And if you are looking at KPC, then you have all these options of meropenem, vaborbactam or ceftazidime, avibactam. If you have resistance to avibactam, relibactam or vaborbactam, then polymyxin based therapy along with high dose carbapenem, and that high dose could be 2 grams TDS to 1.5 grams 6 hourly, along with either an aminoglycoside based or a tigecycline based or a fosfomycin based combination could be there. Similarly, it holds true for pseudomonas and for MDR Acinetobacter, where MDR Acinetobacter, when we talk about polymyxin based therapies, are generally chosen. So if you want to treat your KPC Klebsiella and your MIC is less than 8 for meropenem, right, then the options available are ceftazidime, avibactam along with colistin, or you can add gentamicin or fosfomycin or tigecycline. If you have KPC, KP with MIC of less than 8 for meropenem, but the no options, treatment options are not available, then you can look for high dose meropenem, which is 2 gram 8th hourly to 1.5 gram 6th hourly. Along with that, add tigecycline, again a high dose tigecycline. We are talking about 100 milligrams 12th hourly. Remember, tigecycline is not a very it does not have a good bacterial good bloodstream levels, so it's not an ideal drug for bacteremia. Along with that, colistin or fosfomycin or gentamicin. And if your MICs are more than 8 and new treatment options are not available, then you can have double carbapenem therapy, where ertapenem once daily followed by meropenem every 6th hourly. Plus you can add a third drug in the form of either colistin or poly-B if you have. This is the 2021 IDSA guidelines, where they have looked at all these 3 important bugs that we are dealing with. So MDR infections are the worst nightmare that we face. At risk population should be identified, because this is one category where we will require this combination therapy. And combination means we are talking about polymyxin, tigecycline, fosfomycin, renal safe aminoglycosides, double carbapenems, adding of monobactams to ceftazidime avibactam at present. Always identify resistance mechanism, try to look at your gene specific, and then you can actually modulate your antibiotic therapy. And monotherapy is meant for less sicker populations, and in routine critical care practice the importance is actually dying down. Thank you so much.
Yeah, thank you, Dr. Sachin. Extraordinary presentation, there's no doubt. I just wanted to have one comment and one suggestion from your side. I feel that the burden of MDR XDR, it's partially a man-made disease. First we create the disease and then we treat this disease. So apart from so many of options which you have given, which may be difficult for everybody to actually see and plan for their treatment strategy, I think one should always give a high stress on source control along with all these strategies. That is what I feel, especially in onco-critical care, when you have the tunnel catheters, many hardware devices which are in situ. So unless and until we take care of all those things, I'm sure there will be another presentation with new drugs in the coming years. That is my comment. The second is, I wanted to know your opinion. What is your practice? Do you practice combination therapy in your ICUs? Because a couple of years back, everybody was fighting on this part that monotherapy is something which we should do. And today we have a complete paradigm shift. So what is your policy?
There are 2 categories of patients. One, if we talk about oncology patients, and if they have received chemotherapy, we take them as immunosuppressed. Monotherapy has no role, at least when we are targeting these subsets, if they are coming in sepsis and shock. I do practice combination therapy. Now combination therapy will depend on the exposure to the healthcare. Now if this patient was in the ward for let's say 10 days, was already receiving piperacillin, tazobactam, and to start with some teicoplanin, and he's coming to me, then I don't have an option, because what we see is roughly 70 to 80% of carbapenem resistance nowadays. So yes, I will be jumping to a higher antimicrobial. The choice is either ceftazidime avibactam or a combination with along with EDTA is the choice that we do. When we talk about non-immunosuppressed subset, there we'll still think of high dose carbapenem rather than directly jumping to this category of combination. But yes, combination is still there. Colistin as a reserve drug or polymyxin as a reserve drug. So if I am suspecting a urinary tract infection, yes, colistin. Otherwise, polymyxin B holds a little higher up as compared to colistin. But again, the last choice drug that to be started.
Same combination of antibiotic having a 2 principles. One, to increase the efficiency of the antibiotic to particularly identify organisms. That has got a specific rules and specific principles behind the combination. Just to combine, because the resistance is having a different aspects. And just here from the right from the start from the penicillin, resistance, streptococci, then MRSA, then ESBL, then CRE, and then all these things. There you really need to understand what is the mechanism of the antibiotic to target this.
So all these together is
Patient may not be that sicker, but still you require. So in this way, and we are
That's it.
Yes, this gluten escape is within all around the world. But for Esquadella, in Indian speaks is normal. And where P stage for Sedona, E for E. coli, K for Klebsiella, and S. So, and so I said already started this time. To get the impact of three steps, like and where it is, and hopefully, next chapter.
Sir, in our clinical practice, we see emerging organisms once we are treating a patient for long term in ICU. So, at some point, we do get strains which are cholesterol resistant, and we are still suspecting a gram-negative sepsis. So, obviously, we are using some combination. So, what is your choice of first combination in that scenario when you're suspecting still a gram-negative and you have an organism which is cholesterol negative in the past, or the current one is cholesterol resistant?
See, if you have a colistin resistance, then we are talking about PDR. Now, there is no fixed formula to treat a PDR, right? So, what we try to do is we look at what is the status of minocycline, what is the status of phosphomycin there. I suspect if colistin is resistant, then mostly tigecycline will also be resistant. So here we give a combination. So we will give either ceftazidime, avibactam, or what is called as Eloris. I didn't want to name that, but still it's there, right? So that one drug along with either poly B or phosphomycin along with it. Minocycline has shown sensitivity when we are particularly looking at Acinetobacter. Minocycline does show good sensitivity, so we try to combine this. But otherwise, there is no fixed formula. Sir, आप कुछ बोलोगे? He's looking for water bottle. So, but no fixed formula for them.
See, the problem with the antibiotics is in the Western days, we have been converting the Western knowledge to us. The primary thing is that we are having a very high incidence of CREs. And being a gram-negative, yes, we have, first this combination is there. Therefore, by default, you end up starting with the combination. And then when you get the data, when you get the culture reports, that is the time to de-escalate. And that is where probably monotherapy has a role to play. But in the beginning when the person is sick in the intensive care unit, I think we find difficult. And another thing which I am finding very unusual though is we have just stopped talking about aminoglycosides. And aminoglycosides, now we are all talking about phosphomycin. But still if you see a fairly large number not being used, omeprazole and all sensitivity is back. And they have been our saviors. And in terms of the resistant breakers which you talked about, Eloris, obviously ceftriaxone, EDTA. Now you have combination, or you may have combinations of using alone, then you combine with a large dose of bacter, or you have even with the piperacillin tazobactam. But the only question is, we are all now gaining experience about the data in terms of randomized trial that is relatively limited. But nevertheless, first choice should be the right choice.
Thank you, sir. May I now request Dr. Jitendra to kindly felicitate Dr. Sachin, please. Dr. Sachin, can you please come to the dais? Would now like to request Dr. YP Singh, who's Senior Consultant and Director Critical Care at Max Patparganj Hospital and also Secretary ISCCM, to kindly felicitate our chairperson, Dr. Jitendra. Thank you, sir. Thank you so much.